Welcome. In this session, we'll be discussing the complications of strabismus surgery. Oculocardiac reflex is the decrease in the heart rate on applying traction to extraocular muscles, and it occurs most commonly with the medial rectus muscle. Atropine can prevent this reflex by blocking the parasympathetic vagal pathway. Postoperative nausea and vomiting can occur following eye muscle surgery, and it can be reduced with prophylactic dexamethasone and ondansetron injections, adequate hydration, use of propofol as an anesthetic, and limiting the use of inhalational anesthetics and opioid analgesics, which can provoke nausea and vomiting. Malignant hyperthermia is a genetic susceptibility to succinylcholine and certain inhalational anesthetics, and when the susceptible patient is exposed to these drugs, there is severe increase in intracellular calcium concentration in the skeletal muscles, and this results in raised body temperature, muscle rigidity, and muscle breakdown. Untreated malignant hyperthermia has a fatality rate of 75%, and immediately on diagnosis during surgery, surgery should be stopped, body should be cooled, and intravenous dantrolene administered. During strabismus surgery, a muscle being operated on can be lost when the muscle is either inadvertently transected or when it retracts from the sutures or instruments which are holding the muscle when the muscle is not attached to the globe, and the muscle then retracts posteriorly through its entry point in the tenon capsule into the orbit. A lost medial rectus muscle is the most severe because it is most difficult to retrieve a lost medial rectus muscle, as medial rectus is the only muscle not to have fascial attachments with an oblique muscle which help us to locate a lost muscle. In this diagram we see the tenon and the conjunctiva separated from the medial aspect of the limbus. So what we are viewing here is the inner aspect of the tenon's capsule, and this is the opening of the tenon's capsule through which the medial rectus muscle passes through from posterior to anterior before inserting on the globe. And when the muscle has been disinserted from the globe, the muscle can be lost posteriorly into the orbit through this opening if the sutures and instruments which secure the muscle lose their hold on the muscle. A lost muscle should be searched for immediately, else it undergoes contracture. The proximal end of the muscle is usually located near its entry point in the tenon capsule, and during this procedure it is important that the tenon capsule is not violated, as it can lead to adherence syndrome, which we will be discussing later. Intermuscular septum can be traced to locate a muscle, and oculocardiac reflex can also be used to confirm whether the identified tissue is muscle. And sometimes orbitotomy or transnasal endoscopic surgery is required to retrieve the lost muscle. And if the muscle is not located, transposition of adjacent muscles will be required with attendant risk of anterior segment ischemia, which we will be discussing later in this session. A slip muscle is a muscle which slips from the sutures attaching it to the sclera but remains within the tenon's capsule, and sometimes the muscle slips within its capsule with the capsule remaining attached to the globe. And with a slip muscle, the patient will show weakness of that muscle immediate post-operatively, and urgent intervention is required in case of a slip muscle also to prevent contracture of that muscle. Pulled-in 2 syndrome is dehiscence of a muscle, usually at the junction of the muscle with its tendon, and it occurs most commonly with the inferior rectus and the medial rectus muscles. Thyroid ophthalmopathy, advanced age, previous trauma, myopathy, and previous surgery are risk factors for pulled-in 2 syndrome, and the slipped or the lost portion needs to be located and the 2 portion reanastomosed. Scleral perforation can be detected as extrusion of uveal tissue or vitreous from the site of scleral passage of a suture needle, and scleral perforation can lead to retinal break with retinal detachment or endophthalmitis, but it has been seen that most unnoticed breaks lead to a small chorioretinal scarring, as seen here in this diagram. But when retinal break is suspected, and ideally routinely following passage of the scleral sutures, indirect ophthalmoscopy should be done, and any identified break should be treated with laser. Infections following strabismus surgery can be conjunctivitis, preseptal cellulitis, orbital cellulitis, and endophthalmitis. Conjunctivitis, other than being infectious, can also be due to allergy from suture materials or drugs. Anterior segment ischemia results from interruption of anterior ciliary blood vessels, which are the major source of blood supply for the anterior segment. And anterior segment ischemia occurs when 3 or all 4 rectus muscles are operated on simultaneously. So anterior segment ischemia occurs following rectus muscle surgery, and this is very important to remember. However, anterior segment ischemia can occur following surgery on just 2 rectus muscles, and this occurs particularly in older patients with systemic vascular disease or in patients with immunocompromise. And anterior segment ischemia has been found to be more common following surgery on vertical rectus muscles, which is said to contribute more to the anterior segment circulation than the horizontal rectus muscles. The earliest clinical features of anterior segment ischemia, which is found early on after surgery, are cells and flare in the anterior chamber. Conjunctival chemosis can occur, and severe cases of anterior segment ischemia can have corneal edema, irregular pupil, and cataract. Hypotony can occur due to loss of blood supply to the ciliary body, and anterior segment necrosis can occur due to severe interruption of anterior segment blood supply. So these two photographs shows a patient with anterior segment ischemia 1 day and 1 month post-operatively. The 1 month post-operative picture shows an irregular pupil due to sectoral ischemia of the iris muscles. Treatment of anterior segment ischemia includes topical and or systemic steroids, and the risk of anterior segment ischemia can be reduced by stepwise surgery at least 6 months apart when more than 2 rectus muscles need to be operated on, sparing the anterior ciliary vessels during rectus muscle transection and suturing, and avoiding limbal approach, which interrupts the conjunctival contribution to the anterior segment blood supply. A Dellen is a shallow corneal thinning adjacent to an elevated bulbar conjunctiva. So this photograph shows a patient with a Dellen adjacent to a subconjunctival hemorrhage which has elevated the bulbar conjunctiva. And following strabismus surgery, Dellen occurs more frequently after a limbal approach because of the limbal sutures and swelling of the perilimbal conjunctiva. Dellen disappears with time with subsidence of the bulbar conjunctival swelling, and lubricants are given till the swelling of the bulbar conjunctiva subsides. A pyogenic granuloma appears as a reddish swelling composed of proliferated capillaries at the site of conjunctival closure, and it is prone to ulceration and bleeding. However, it responds to topical steroids, otherwise it will have to be excised. Epithelial inclusion cysts are non-inflamed subconjunctival cysts as seen in this photograph, and it arises from epithelial implantation or conjunctival infolding at the site of muscle suture or conjunctival closure. Epithelial inclusion cysts require excision, and careful dissection is necessary near a muscle suture as the tendon may be attached to the cyst. Conjunctival changes following strabismus surgery include thickening, hyperemia or pinkish appearance of the conjunctiva in the area operated, and there are several causes for this to happen. During muscle resection, there can be excessive advancement of the thick tenon capsule closer to the limbus, or the plica semilunaris can be included in the conjunctival closure by mistake, or in a long-standing large angle strabismus, redundant conjunctiva can remain over a resected muscle. Treatment includes excision of redundant conjunctiva, or resection or recession of scarred conjunctiva and subconjunctival tissue with closure by a conjunctival or amniotic membrane graft. Adherence syndrome occurs following tears in the tenon capsule, which results in prolapse of retroorbital fat into the subtenon space, which is the space between the globe and the tenon capsule. And this prolapse of retroorbital fat results in fibrofatty scarring restricting motility of the globe. Adherence syndrome occurs most frequently after surgery of the inferior oblique muscle because the posterior border of the inferior oblique muscle is near to the retroorbital fat space lying behind the Tenon's capsule, and prolapse of retroorbital fat in this location results in fibrosis of tissues around the inferior rectus muscle, leading to progressive hypotropia, esotropia, and excyclotropia. And if prolapse of retroorbital fat is noted intraoperatively, the prolapsed fat is excised and the tear in the tenon capsule can be sutured. Changes in lid position can occur after strabismus surgery, and this usually occurs following surgery of the vertical rectus muscle, and surgery on the inferior rectus muscle is most prone to cause changes in the position of the lid. Recession of inferior rectus muscle can lower the lower eyelid margin, and resection of the inferior rectus muscle can elevate the lower eyelid margin, and this can be reduced or prevented by separating all fascial attachments of the inferior rectus muscle up to 12 to 15 millimeters posterior to its insertion. Surgery on two horizontal rectus muscles of one eye can induce astigmatism, although this is usually temporary, and oblique muscle surgery can change the axis of pre-existing astigmatism. Diplopia can occur post-operatively in older children and adults, and it can occur due to undercorrection, overcorrection, or pre-existing anomalous retinal correspondence. Pre-existing anomalous retinal correspondence causes paradoxical reverse diplopia even after perfect alignment following strabismus surgery. The postoperative diplopia may disappear or may persist. It may disappear because of development of fusion, which can eliminate the diplopia due to development of suppression in a child under 10 years of age. The paradoxical diplopia of anomalous retinal correspondence slowly disappears with time, and since a mild overcorrection is targeted immediately postoperatively, the diplopia due to this overcorrection disappears in the first few weeks after surgery as the deviation drifts back to orthotropia. Treatment of postoperative diplopia include occlusion, prisms, botulinum toxin, or realignment of muscles. And patients with unequal vision in the two eyes may ignore the dimmer blurred image from the eye with poorer vision. Unsatisfactory alignment following strabismus surgery can occur early or late following surgery. Early postoperative misalignment can occur due to overcorrection. However, as we have mentioned, early mild overcorrection is targeted because there is a natural tendency of the deviation regressing in the first few weeks following surgery. Early postoperative misalignment can also occur due to undercorrection or due to development of a new strabismus pattern. Late postoperative misalignment can occur from poor vision, which is very important to remember, poor fusion, and weakness of the operator muscle due to formation of a stretched scar, also called a pseudotendon. So strabismus surgery in a patient with poor vision is likely to recur, and this is very important to remember when planning surgery in such a patient. Treatment of misalignment includes prism, botulinum toxin, and reoperation, which includes removal of scar tissue if there is scarring causing weakness or restriction, but otherwise reoperation usually targets the non-operated muscles. Reduced elevation of the operated eye is a special situation, and it can occur in two circumstances. One is iatrogenic Brown syndrome, which follows excessive tightening of the superior oblique muscle and where there is restricted elevation in adduction. And if the superior oblique muscle has been tightened by a tuck procedure, it can be reversed in the early post-operative period. Anti-elevation syndrome follows anteriorization of the inferior oblique muscle, and in this situation there is restricted elevation in abduction. To recap the salient points, malignant hyperthermia results from a genetic susceptibility to certain muscle relaxants and anesthetics. It results in muscle rigidity and is potentially fatal. Urgent intervention is required for a lost or slipped muscle, which results in impairment of muscle function before contracture sets in. Pulled-in syndrome results from dehiscence of the muscle, usually at the junction of the muscle with its tendon. Scleral perforation can lead to retinal detachment and/or endophthalmitis, and when suspected, immediate intervention should be instituted. Anterior segment ischemia is likely following surgery on 3 or more rectus muscles. However, it can even occur following surgery on 2 rectus muscles, particularly in patients with systemic vascular compromise and immunocompromise. Earliest sign of anterior segment ischemia is anterior chamber cells and flare, and severe cases of anterior segment ischemia can have corneal edema, pupil distortion, and hypotony. Ocular surface changes which can occur following strabismus surgery include Dellen, pyogenic granuloma, epithelial inclusion cyst, and conjunctival changes which can occur following inadvertent advancement of the Tenon's capsule during a muscle resection or inclusion in the conjunctival closure of the plica semilunaris. Adherence syndrome occurs following violation of the Tenon capsule, which leads to prolapse of retroorbital fat between the globe and the tenon, and this produces fibrofatty scars involving the muscle, resulting in movement limitation. Changes in lid position usually occur following surgery on vertical rectus muscles, particularly if the muscles are not separated from the surrounding structures. Early residual strabismus can occur due to overcorrection, undercorrection, or a new strabismus pattern. Mild overcorrection immediate post-operatively is actually targeted to nullify the natural post-operative drift. Late development of strabismus can occur from poor vision, poor fusion, or development of a stretch scar. Thank you for listening.